Session now. So welcome everyone again. My name is Erica Shinoy. As I mentioned, I'm the medical director of our regional emerging special pathogens treatment center here at MGH, and I'm really thrilled to be here moderating a session by two terrific physicians and subject matter experts. Today, we have Dr. Caitlin Dugdale, who is an infectious diseases physician at Mass General Hospital and an assistant professor of medicine at Harvard Medical School. And she's joined by Dr. Jacob Lazarus, who's also an infectious diseases physician here at the Massachusetts General Hospital and an instructor in medicine at Harvard Medical School. And both Dr. Dugdale and Dr. Lazarus are active members of our biothreats team at the regional center. Next slide. This is an acknowledgement that the webinar is presented by the RESPECT in collaboration with the Region 1 Disaster Health Response System, the RDHRS, and these programs are funded by the ASPR within the Department of Health and Human Services. Just to let you know, this webinar is being recorded and the recording is going to be posted on the Region 1 RDHRS website, and that link is in the chat for you. You can also join the conversation on social media by following and tweeting at Region 1 RDHRS. Next slide. So you can see the disclosure here. Keep going, next slide. And this is the official welcome. We'll go to the next slide. We've already introduced ourselves, or at least I've introduced myself and introduced our two wonderful speakers today. We'll go to the next slide. These are the learning objectives that were described in the flyer. So you'll get through all of these today and possibly more when we get to the question and answer session. Next slide. And now I'm going to turn it over to our first speaker.
Thanks so much for the introduction, Dr. Shinoy. So again, I'm Caitlin Dugdale, an infectious diseases physician at Mass General, and I'll be starting off the presentation today. Emerging special pathogens, including avian influenza, the importance of identify, isolate, inform. Next. So the roadmap for today's presentation includes first, an introduction to the identify, isolate, and inform framework. And then we'll talk about the application of that framework to high consequence infectious diseases, which we'll abbreviate throughout the talk as HCIDs. We'll also be discussing the geographic reach and clinical syndromes, in particular for Middle East Respiratory Syndrome, or MERS, viral hemorrhagic fevers, and then we'll have a special focus on avian influenza. Next. So the CDC developed the Identify, Isolate, and Inform tool in 2014 to facilitate early recognition of and action for patients with possible Ebola virus disease. And the first element of this tool speaks to the importance of identifying an exposure history and signs and symptoms potentially consistent with Ebola virus disease or other HCIDs, then isolating the patient and determining personal protective equipment or PPE that might be needed, and finally to inform hospital infection control, appropriate staff, and the local health department. And after its initial development for Ebola virus disease back in 2014, this same framework has been adapted for many other high consequence infectious diseases. And it really just emphasizes that the statement that early recognition is critical for infection control. Next. So we'll go through each of the I's individually. For the first I, identify, again, that speaks to the importance of identifying both a travel or exposure history and symptoms potentially consistent with an HCID. So one might ask, has the patient had contact with an individual with a confirmed HCID or traveled to a country with widespread HCID transmission within the prior so many days, whatever the incubation period is for the disease of interest? And if the patient traveled to a country with ongoing HCID transmission, we encourage providers to ask about the specific cities or districts that were visited, as often these high consequence infections are only circulating in a given region and may not be circulating widely throughout a country. Next, it's important to ask, does the patient have any symptoms compatible with the HCID of interest? And we'll of course go through those in more detail. Every healthcare facility should have some mechanism for identifying patients with a traveler exposure history and symptoms potentially consistent with an HCID. One approach that we take at Mass General is actually the document shown on the right-hand side of the screen, where we list country by country where there are ongoing or recent outbreaks of HCIDs, the HCID of concern, the relevant incubation period, and then on the far right-hand side of that document, a link out to the first steps that a provider should follow after identification of a possible patient with an HCID. And this document, of course, takes a lot of effort to maintain. It is updated regularly, but especially given our proximity to Logan and our role in Region 1, it's important that we have some living document like this to advise clinicians. Next. So to build that kind of document, I've included a number of resources on this slide that others can refer back to after the talk. We monitor CDC travel notices, the CDC outbreaks page, WHO outbreaks page, and some materials from the UK Health Security Agency, which provide very up-to-date information about ongoing outbreaks of concern. Next. So there are many different approaches that a facility can take to moving towards better identification of individuals with possible HCIDs. And that might be very low tech. It can be as simple as placing a sign at arrival that encourages patients to self-identify as having traveled internationally in the last 21 days or self-identifying if they have a fever or other symptoms, depending on outbreaks of concern. There are also much higher tech options, and at Mass General, we've been working on developing a clinical decision support tool to aid healthcare personnel in identifying individuals with HCIDs. And there's an example of a CDSS form on the right-hand side that we developed for Mpox infection, but that sort of form can be embedded within the health record, embedded into clinical workflow, and adapted for things like HCID screening. Embedded clinical support tools have been demonstrated to improve adherence to guidelines, and in the setting of shifting PUI definitions and infection control guidelines and testing strategies, clinical decision support may be particularly useful. One thing that we've also found is that having some sort of documentation in the patient record about the assessment for an HCID, like through a CDSS, can assist in communication between healthcare personnel about patient evaluation and status. Next. So if a patient is in a clinical care setting and is identified to have had a travel or exposure history and symptoms potentially consistent with an HCID, we recommend isolating the patient immediately. And the patient can be placed in a private room, preferably enclosed with a private bathroom or covered commode, and it's important that they are wearing a facility-issued face mask. If an airborne infection isolation room is available, that's preferred, but if not, you can use a standard patient room with the door closed. And guidelines recommend avoiding unnecessary direct contact, including phlebotomy or other procedures that aren't required for immediate stabilization, and also to minimize personnel in the patient's room as appropriate. If they're available, we encourage using remote monitoring and communication devices, even cell phones, to evaluate the patient and conduct a further history. And if direct patient contact is necessary, healthcare providers should use appropriate PPE, which we'll be reviewing for each of the HCIDs covered in this talk. Next. After a patient with a traveler exposure history and symptoms potentially compatible with an HCID has been isolated, it's important to inform your facility's local points of contact immediately and then contact the local health department. And the local health department will provide guidance regarding whether or not the patient should be considered a person under investigation or PUI officially. And if they are a PUI, they'll provide guidance on testing for the HCID. If the patient is determined by the local health department to be a high-risk PUI for a given HCID, they may coordinate transfer to a different facility, such as an assessment hospital in the case of Ebola virus disease, an Ebola treatment center, or to the regional special pathogens treatment center, which for Region 1 is MGH. Next. So we'll talk about the application of the Identify, Isolate, Inform framework relevant to some cases that we recently had on the MGH Biothreat Service. So for case 1, this is the case of a 23-year-old man who returned from a 3-week trip to Qatar 5 days ago, now presenting with a dry cough, myalgias, dizziness, and fevers that started the same day as his return. He had no sick contacts while abroad, and he didn't visit any healthcare facilities. But of course, he did take a 30-minute camel ride during which he was provided with milk that, quote, tasted funny, that he suspects was camel milk. At arrival, he was noted to be generally well appearing and afebrile with an oxygen saturation of 98%, but with an ongoing dry cough. Next. So because we've embedded some of the screening for these high consequence infectious diseases into the clinical workflow and into the EHR, after entering kind of responses to form questions, providers received this best practice advisory, warning them that this patient might meet criteria to be a PUI for MERS and that the patient should be isolated immediately and that the biothreats team should be informed. Next. So in terms of identify, at arrival to the MGH ED, the patient was identified as having both a potential exposure, the travel and the camel milk ingestion, and symptoms potentially consistent with MERS with ongoing cough and fever. He was promptly isolated. A mask was placed on the patient when he was identified in ED triage, and he was taken to an airborne infection isolation room, though again, if none were available, he could have been placed in a standard patient room with the door closed. Non-necessary procedures or encounters with healthcare personnel were minimized, and all kind of direct patient contact was conducted with PPE for airborne contact and droplet precautions, including a gown, gloves, eye protection, and a fit tested N95 respirator or PAPR. And then the MGH biothreats physician on call was informed to discuss the case. Next. So let's review a little bit of the Middle East Respiratory Syndrome or MERS epidemiology, because that's important for identifying patients with this potential disease. MERS is caused by MERS-CoV, which is another coronavirus. Obviously, we're getting a lot more experience with coronaviruses. The primary geographical risk area is the Arabian Peninsula, though, as you can see in the graph on the right, the vast majority of cases are from Saudi Arabia, which is the country that's highlighted in blue on that graph, over 80%. Sources of infection include droplet particles, so there's still ongoing discussion about whether possible airborne transmission is at play. Direct contact with the contaminated environment, particularly in healthcare facilities, and direct contact with camels or consumption of raw camel milk. And the incubation window is 2 to 14 days. Now, fortunately, in 2023, as we can see in the table at the bottom right of the slide, there's only been one case so far back in January and no other confirmed cases of MERS in February, March, or April so far, that we don't have data for May yet. So that's a positive trend. Many fewer MERS cases this year thus far. Next. In terms of symptoms, patients present with a cough, fever, shortness of breath, and occasionally GI symptoms. Most of these cases are severe, with about a 35% case fatality rate, but mild and asymptomatic cases have also been reported. And you can see the CDC PUI criteria for MERS on the right-hand side of the screen, which requires either that somebody have severe illness and a history of travel or known membership in a cluster of patients with a severe illness, or they can have milder disease, just fevers, but not necessarily pneumonia, as well as a history of being in a healthcare facility in one of the countries with active MERS circulation or close contact with a confirmed MERS case. And I think it's important to note here that actually camel or camel milk exposure is not part of the CDC PUI criteria, but that's still something that should raise suspicion. Next. So we do know that dromedary camels are an animal reservoir that occasionally transmits MERS-CoV to humans, and there was a good article published back in 2018 in the journal Viruses at the bottom left-hand side of the screen, in which investigators looked at contact with dromedaries among laboratory-confirmed MERS cases reported to the WHO between 2015 and 2018. And what they found was that for primary cases that where transmission from another individual wasn't known, the majority of those individuals had had contact with dromedaries, 191 of the 235 in the study. And of those 191, 137 of them had actually consumed unpasteurized camel milk. So there's a very strong association with camel milk ingestion and possible primary MERS cases. Though again, it's not part of the official PUI criteria at this time. Next. So there are some additional infection control and laboratory considerations to be aware of. First, precautions for care of patients with confirmed or suspected MERS include standard contact and airborne precautions, which include gown, gloves, eye protection, and N95 or PAPR. And then a patient should be placed in an airborne isolation room if that's available, but if not, again, a standard patient room with a closed door for the initial assessment is reasonable. And there's additional details from the CDC about MERS infection control guidance that are available on the QR code on the right-hand side of the screen. Fortunately, there's no special laboratory measures that are needed to handle specimens for patients with confirmed or suspected MERS. And if MERS-specific testing is recommended by local health authorities, that involves collecting 3 different specimen types: a lower respiratory tract specimen, 2 different upper respiratory tract specimens, both the nasopharyngeal and oropharyngeal swabs, and then also collecting a serum specimen for either serology or PCR. Next. So a bit of follow-up about this first case. In this patient's case, his chest x-ray was negative for pneumonia, and an extended viral respiratory PCR panel actually returned positive for influenza B. So with a clear alternative diagnosis and low overall risk of MERS based on the current MERS incidence, no further evaluation was indicated for MERS at that time. Airborne isolation precautions were therefore discontinued, and he was put into droplet isolation precautions for influenza B infection. Next. So now we'll turn to a second case, again, that we had very recently on the Biothreat service. This is a case of a 46-year-old man presenting from Logan Airport after arriving from Nigeria with about a 3-week history of fevers, headaches, and vision changes. He had been admitted to a hospital in Abuja, Nigeria, almost 3 weeks ago, where he was found to be in renal failure requiring hemodialysis for a week. He also had pancytopenia at that time. When he presented to the outside hospital, he endorsed abdominal pain, nausea, and diarrhea. He had no overt hemorrhaging, and he also denied rodent exposure or sick contacts. At the outside hospital, he was diagnosed with malaria, though it's unclear whether that was a presumptive diagnosis or if that was actually confirmed with a laboratory test. Either way, he was treated for malaria, but he reported that he continued to have fevers for the following 3 weeks, all the way up until the day prior to his MGH presentation. With headaches and vision changes at the hospital in Nigeria, he had a head CT that had demonstrated a pituitary mass, for which neurosurgery was recommended in Nigeria. But when his family was notified of this, they organized his travel to the US for further management. So at arrival to MGH, he was noted to be clinically stable and afebrile, but with left-sided hemianopsia. Next. Headaches and fevers, despite malaria treatment, earlier GI symptoms, and then the prior renal failure. He was isolated. A mask was placed on the patient upon his identification in ED triage. He was then taken again to an airborne infection isolation room, but we would emphasize if that's not available, he should have gone to a standard patient room with the door closed as an alternative. Non-necessary encounters with healthcare personnel were minimized, so no labs were obtained. And initial care was delivered with what we call assessment PPE, including fit tested N95, eye protection, gown, and gloves. But further care should be delivered with viral hemorrhagic fever precautions, which we'll go into in more detail. So the Biothreats MD on call was contacted to discuss the case, which was actually subsequently also discussed with the medical director at the Massachusetts Department of Public Health. Next. So we'll review briefly a little bit of Lassa fever epidemiology, as there is an ongoing outbreak. Lassa fever is endemic in West Africa, and there's an ongoing outbreak in Nigeria, including with cases near Abuja, which was the city that the patient had traveled from. And just this year, there have been over 5,000 suspected cases, 918 confirmed cases, and 156 deaths in Nigeria from Lassa fever. And on the right-hand side, you can see a map of where Lassa fever is endemic in the countries in blue, and where with the countries in green, Lassa fever kind of is detected intermittently through more sporadic outbreaks or cases. Sources of infection include exposure to food or household items that are contaminated with the urine or feces, including aerosolized particles of urine and feces of an infected multi-mammate rat or multi-mammate mouse, which is also called an African rat, and secondary human-to-human transmission via direct contact with blood, secretions, organs, or other bodily fluids has also been described, of course. The incubation window is usually 7 to 10 days, but it can be up to 21 days. Next. Symptoms of Lassa fever include fever, headache, fatigue, and GI symptoms, though those are less common. And 80% of the cases are actually asymptomatic or mild, but they can be severe in the other 20% and involve multi-organ system failure and or hemorrhage. So the overall case fatality rate is 1 to 3%, but is closer to 15% among individuals who are hospitalized. Next. For this case, in discussion with the Massachusetts DPH, the patient's improvement after malaria treatment with resolution of his renal failure, his lack of sick contacts or rodent exposure, and overall clinical progression over the prior 3 weeks were thought not to be consistent with Lassa fever. So no further VHF testing was recommended. He was admitted for further workup of the pituitary mass, which had brought him to the US, and he was admitted under airborne precautions for possible TB, but a broad infectious workup was subsequently negative and precautions were removed. Next. So for the sake of time, we're not going to go through all of the viral hemorrhagic fevers in detail, but I do want to discuss them briefly. We've already touched on Lassa fever, which is at the top of this table. Next, of course, we have Ebola virus disease, abbreviated as EVD. Unfortunately, there's no active Ebola virus disease outbreak that we're aware of right now, though of course there was a recent outbreak of Sudan Ebola virus in Uganda late last year. Modes of transmission include direct contact with blood, bodily fluids, and tissues of infected animals or humans, and this does include funeral rites. And there's a suspected bat reservoir with Ebola virus disease. Incubation is usually 4 to 17 days, but can be up to 21 days. And symptoms include fever, fatigue, headache, myalgias, GI symptoms, conjunctivitis, and the hallmark bleeding and bruising, though that classic kind of hemorrhagic fever symptom is actually present in less than half of cases who have confirmed Ebola virus disease. The case fatality rate ranges from 50 to 90% based on the location of the outbreak and the strain involved. But is obviously quite high. Very similar to Ebola virus disease is Marburg virus disease, and there is ongoing transmission of Marburg at present in both Equatorial Guinea and in Tanzania. There have been about 25 confirmed cases and almost as many cases that were suspected, though as per WHO communication from a couple of weeks ago, there have been no new cases diagnosed since late April. Modes of transmission include contact with infected bat feces or aerosols or human-to-human contact via bodily fluids. And the incubation period for Marburg is usually 3 to 10 days, but can be all the way up to 28 days. And symptoms are very similar to that of Ebola, also with a 50% case fatality rate. Lastly, we have Crimean Congo hemorrhagic fever, which is abbreviated CCHF. And the geographic distribution of CCHF is much wider, including Eastern Europe, Africa, the Mediterranean, the Middle East, and parts of Asia and India. There were actually a number of cases of CCHF that were diagnosed when investigators or individuals in Uganda were being tested for Ebola virus disease last year, because there is some overlapping geography. Unique among the viral hemorrhagic fevers, though, CCHF can be tick-borne. It is also transmitted through contact with an infected animal's blood or human-to-human contact via bodily fluids. And one of the very common ways or populations in whom it's diagnosed are those with occupational exposure to infected livestock. The incubation period for CCHF is 1 to 13 days, and the symptoms include fevers, myalgias, GI symptoms, rash, and then occasionally bleeding and bruising. And the case fatality rate for CCHF is a bit lower at 12 to 40%, though still considerable. Next. So if a patient is in the clinical care setting and is identified to have had a travel or exposure history and symptoms potentially compatible with viral hemorrhagic fever, Isolate the patient immediately, and further care should be administered depending upon the patient's clinical status. These PPE recommendations are taken from CDC guidance, and you can get more details about the PPE donning and doffing guidance at the QR code on the right. They were originally developed for Ebola virus disease, but are applicable to all of the viral hemorrhagic fevers. So over on the left-hand side, if we have a clinically stable VHF or EVD PUI without bleeding, vomiting, or diarrhea, the PPE that's recommended includes a single-use fluid-resistant gown extending to the mid-calf, a single-use face mask, a full face shield, and 2 pairs of single-use gloves with extended cuffs. If we have an individual with a confirmed VHF for Ebola virus disease or a PUI with bleeding, vomiting, diarrhea, or instability, there are additional layers of PPE that are recommended. And so in that case, a single-use impermeable jumpsuit with integrated boots is recommended, as well as a PAPR or disposable N95 respirator that must be used in combination with a single-use surgeon hood extending to the shoulder and a full face shield. 2 pairs of single-use gloves with extended cuffs are again recommended, but also for the more unstable or folks with bleeding, vomiting, or diarrhea, it's recommended to use single-use boot covers to the mid-calf, as well as an apron from the torso to the mid-calf. Next. There are also some important laboratory considerations, both in the collection of specimens and then their processing for viral hemorrhagic fevers. So it's recommended to limit phlebotomy procedures and lab testing to the minimum necessary for essential diagnostic evaluation and care. The CDC recommended clinical lab tests for an returning traveler include basic chemistries, liver function tests, PT-INR, a BINAX or rapid malaria test, urinalysis, and blood cultures. But here we would emphasize the importance of prioritizing basic chemistries in a BINAX malaria test, particularly given the symptom overlap between malaria and some of these HCIDs. Blood for VHF testing to both the state and the CDC may be indicated after discussion with public health authorities, and any samples collected should be hand carried to the laboratory after placing them in a leak-proof secondary container. Next. Once the specimens arrive in the lab, there's additional considerations. So laboratory personnel should be trained in donning and doffing appropriate PPE, which for the lab would include single-use exam gloves with extended cuffs, use of a fluid-resistant gown, a surgical mask or other respiratory precaution, and then eye protection. Specimen manipulation should be performed in a Class 2 biosafety cabinet, and use of a centrifuge should be avoided if possible, but if necessary, does carry a risk of aerosolization, so additional measures should be considered. All of that said, generally, the risk of VHF transmission in a clinical lab is actually similar to other bloodborne pathogens like HIV, hepatitis B, and hepatitis C, but these additional precautions are recommended just given the high consequences of these infectious diseases. So with that, I'll go ahead and turn it over to Dr. Lazarus.
Thanks very much, Dr. Dugdale. Okay, on to case 3. So this is a 76-year-old woman from rural Fuyang Prefecture in China who presented to RED after arriving in Boston 1 week prior to visit her daughter. Her symptoms are conjunctivitis, headache, cough, and malaise since 2 days prior to presentation. She denied known sick contacts either in Boston or in China. Social history revealed that in China, she lived with her son who does not keep poultry, but their neighbor does have a flock of ducks, but to her at least, they appeared healthy. On exam, she was generally well appearing, afebrile with normal oxygen sats. She had normal conjunctiva and was noted to have a mild, intermittent, non-productive cough. And auscultation was remarkable just for rhonchorous breath sounds that did clear with coughing. All right, so upon initial triage, the patient was identified as having a clinical syndrome compatible with avian influenza and recent travel from a region with higher incidence of human infection with avian influenza. So the patient was then isolated to limit the potential spread to healthcare workers, other staff, and other patients. A facility-issued mask was placed to limit spread from a possible infectious source. She was placed in an airborne infection isolation room to further reduce environmental exposure. And since she was clinically stable, additional history was obtained over the telephone. To further break the potential chain of transmission, when healthcare worker contact was necessary, these visits were conducted using airborne contact and droplet precautions, using the PPE that you see there, and of course, hand hygiene. We on the MGH Biothreats team, a part of our infection control and special pathogens apparatus, were then informed to discuss next steps. Ultimately, the patient's chest x-ray was negative for pneumonia, and PCR revealed the presence of SARS-CoV-2. So with a clear alternative diagnosis, that is COVID-19, as well as no epidemiologic criteria to support avian influenza, the evaluation ceased. She stayed on isolation precautions appropriate for COVID-19 and continued her care for that. Okay, so this case highlights some of the clinical manifestations and epidemiologic risk factors for avian influenza. So let's dive in further. But first, let me start by being reassuring. There is no ongoing human-to-human transmission. Avian flu will likely need to acquire several new mutations to be able to do that with any efficiency. And even then, I think the skills that we've built from COVID and preparation for other HCIDs will be very transferable. And we already have a drug with some efficacy, that is oseltamivir. All right, so a quick virology review. Influenza A and B of the 4 types of flu viruses are those that cause disease in humans, and influenza A viruses are those that have experienced pandemic spread in the past. We type flu viruses based on the hemagglutinin and neuraminidase surface proteins, abbreviated H&N. There are multiple subtypes of each, and at the highest level, we describe a virus by the combination of H and N proteins. So the relatively minor mutations that occur year to year in circulating human flu A viruses is called antigenic drift, and immunity is relatively well preserved in those with previous vaccine or infection-mediated immunity. In contrast, large deadly pandemics occur when recombination of major segments of the influenza genome, so-called antigenic shift, when that occurs. So flu A is not just endemic to humans, but there's also related flu A viruses in dogs, bats, horses, but most consequentially in pigs and birds. Influenza viruses have a segmented genome, which allows reassortment during rare events of co-infection with multiple virus subtypes. You can imagine this occurring when a host is infected with, for example, both a human-adapted flu A and a bird-adapted flu A. Importantly, each of the past 4 flu pandemics has been caused by viruses with genes of avian origin. This is a figure from an initial effort to investigate the 2009 H1N1 outbreak, which many of you remember caused considerable mortality. Ultimately, it was discovered that over the preceding 10 or even 20 years, reassortment had been occurring between swine, avian, and human-adapted flu A, ultimately leading to the development of a pathogenic human-adapted flu A to which many people had limited immunity. Experts worry that the stage may be being set for something similar now with highly pathogenic avian-adapted H5N1, which I'll just call avian influenza or H5N1. So this was first detected in the late 1990s in association with an outbreak at a Hong Kong bird market, where 1/3 of the people known to be infected died. The next prominent human spillover was detected in 2003, where a child and her father died after having contact with live chickens. And at this point, multiple outbreaks begin to be reported among poultry in Asia. And subsequently, infected, dead, wild migratory birds are discovered across Asia, and then North America. And in the last 2 years, it's clear that it's become highly established in wild waterfowl, particularly migratory ducks. And, these wild migratory birds are then capable of spreading it back to domestic poultry where it likely originated. This article from NBC describes the more than 40 million birds that have been culled domestically to limit the spread of H5N1. By now, it's probably more than 60 million. Avian H5N1 has taken a toll on wild bird populations too, most consequentially on birds with threatened or endangered status. This gentleman on the left is a California condor, really only recently rescued from the brink of extinction with massive conservation efforts. They are being hit really hard. Bald eagles are also being affected. The figure on the right demonstrates the alarming rates of nest failure. That is when bald eagles fail to fledge eaglets. In this case, because both of the parents have died. The authors point out in this figure that nest failures are more common in coastal areas where wild sea ducks known to be affected by avian H5N1 roost. I'll just quote because it's a really remarkable article. So the authors note that during the time of observation, 22 bald eagles were diagnosed with fatal, highly pathogenic flu based on pathology, and it describes the pathology here. And among these, 5 actively breeding adult eagles were observed to fall from the nest or were found beneath a nest. And 2 of the adults were observed actively nesting 1 to 2 days before death. So quite pathogenic in some birds. And cases have begun to be reported in other mammals. So reports are popping up of domestic pets coming down with avian H5N1. This unfortunate cat in Nebraska apparently has avian H5N1. So one more reason to keep cats indoors. And this was a dispatch that was just published in the Emerging Infectious Disease journal right up in our backyard up in Maine. There was a significant die-off of harbor seals, which, unlike bald eagles, don't prey on other birds, but do share coastal habitat with them. And we do know that in humans, like in other mammals, cases of avian influenza continue to be severe. This spring, a person in Chile acquired avian influenza, and the last update we have is that a month after symptom onset, he remained intubated. The thought is that he might have had direct or indirect contact with local water birds because nearly identical virus was recently identified in bird carcasses. Of note, while there was report of 1 mutation in his sequenced virus that's predicted to improve efficiency of replication in mammals, there was no human-to-human transmission identified. And importantly, the most likely scenario for the evolution of this mutation is actually within the host. So within this person as the virus replicated, from cell to cell inside of him. This has been seen in different flu viruses before, and of course, we've seen this phenomenon in patients with COVID-19. So clearly, this is an increasingly widespread, highly pathogenic strain of flu present among wild and domestic birds and pathogenic to mammals when it reaches them. So given this, there's considerable worry that avian H5N1 could become adapted to human transmission. And, of course, the nightmare scenario is that it maintains its considerable virulence. But this appears to have not yet occurred, and the virus still seems quite poorly adapted to human transmission. All known cases continue to involve direct or indirect exposure to birds, overwhelmingly to domestic birds, not wild birds. Specifically, the major epidemiologic risk factor is unprotected close contact with sick infected birds or their carcasses or contaminated fomites. And, just to reiterate, the one recent case in the United States was reported among a domestic poultry worker who was culling birds known to be infected with avian H5N1. What are the clinical manifestations of avian influenza? Generally the same as seasonal human-adapted influenza. Incubation period is 3 to 5 days, but maybe as long as 7 to 10 days. Most reports in the literature are of severe manifestation, but hopefully there is bias both in the detection of disease and of publication. But certainly the death in children and young adults and overall high mortality is worrisome. So what can we do? We follow the same infection control framework that we do for all high consequence infections. Who are patients who we should suspect as possibly being infected with avian H5N1? Well, these are patients with the familiar signs and symptoms of flu, and crucially with epidemiologic criteria. So that means, again, recent close unprotected contact with sick or dead birds with confirmed or suspected avian influenza, or with people with contact with such birds. In terms of travelers, because of widespread live animal markets and smaller scale poultry farming, like in the case that we depicted, this is mostly a concern for travelers returning from China and Southeast Asia, though transmission in the US is possible, as I said. So after you've identified a person with possible avian H5N1, you ensure they're wearing a facility-issued face mask, like anyone with an unknown respiratory illness. Airborne infection isolation is preferred, but if not available, a private standard room with the door closed can be utilized. Then, if possible, limit the number of healthcare workers in contact with the patients and wear appropriate PPE, detailed here. And then inform your institutional infection control and coordinate with public health for questions regarding testing. Regarding testing, avian H5N1 will be detected on standard influenza A testing, but this will not distinguish between circulating human and avian adapted H5N1. So samples will need to be sent to local and national public health authorities. Whenever you are considering avian influenza, like for severe seasonal human-adapted influenza, patients sick enough to be presenting to the ED should undergo empiric treatment with oseltamivir. There have been no RCTs, it would not be ethical, but small retrospective analyses suggest that patients treated with oseltamivir may have lower mortality, and like with seasonal influenza, early administration is better. Nevertheless, there may be benefit in administering drug even 6 to 8 days following symptom onset. Okay, well, that was a whirlwind. We really appreciate you joining us. To conclude, embedding screening for travel and symptom screening into the clinical workflow is critical to identifying HCIDs. Pre-existing workflows must be in place to rapidly isolate patients and inform public health authorities. Thankfully, the HFs are currently circulating only at low levels, though continued vigilance is important in travelers from Africa with compatible symptoms, given in particular the ongoing Lassa activity that Dr. Dugdale detailed. Avian influenza, specifically highly pathogenic H5N1, is widely circulating in wild and domestic birds in a really unprecedented manner. And while cases in mammals have been severe, they have been rare, and the virus is not adapted for human-to-human transmission. Intensive genomic surveillance continues. Oseltamivir is likely active, and actions by veterinary and public health authorities, I think will have it be so that a relatively fast route to human vaccination will be available if needed. All right, thank you. And I think we should now have time for questions.
Terrific. Thank you, Dr. Lazarus and Dr. Dugdale. So I'll work through some of the questions that have been in the chat and pose them, and then also invite some of our other team members if they have thoughts and want to weigh in on some of the questions that may pertain to them. But first, there was a question about that outbreaks of concern list that we showed, and this may lead into the next question, but Stephanie Lane from our team has posted in the chat a link to our MPOX toolkit. And if you scroll through that, you'll see there's actually a template where you as a facility can plug and chug the countries and the infections and the notification that you'd like to make for your own facility. As was discussed by Dr. Dugdale, it's really important to have a team that can maintain that list and keep it up to date. Internally here, we have a process where at least once a month, we go through many of the resources that were described to just take a look and see if there are any updates that we want to make. And that's also a very good time to educate the team on what's going on in the world. So would recommend that you take a look at that. And if you discover that there are tweaks that you think would be helpful for that toolkit, please do reach out because we're always looking to improve our tools. So I'll turn to the first one, which is, we talked a lot about some of the workflows and electronic health record supports that that are in place and try to automate the response and clue in the clinicians, those things that are generating those best practice advisories that click off for the clinicians, and then key them into getting some, starting those initial isolation steps, if not already started, and then informing the right people and gathering the information. But many places don't have those facilities. Most places are on electronic health records, but it is resource intensive and challenging to actually build all these in. But you can get pretty far without automation. And so I'll start here and then ask if Dr. Lazarus or Dr. Dugdale want to comment on this further. But the first part is ensuring that the team has the knowledge available to them, and it may not be embedded in the electronic health record, but it certainly can be easily available. And I'll give an example: that outbreaks of concern list, that is accessible, not embedded in the EHR, but as a link out of the EHR. And so if a clinician is wondering, this person came from this country, I didn't have an alert, they can still go to that list and quickly link out to a CDC resource or another resource that may be available. So making things easily accessible. I think the next piece is, while pen and paper is good, many of these things get updated. And so that's why keeping it on a website and teaching the frontline clinicians not to print things out and instead to go to the website is a best practice. I'll stop there and see if there's any other comments from the group about how to incorporate this in a non-automated way within your clinical practice or workflows.
Yeah, thanks, Erica. Of course, I mean, I think we've really benefited at MGH from having the luxury of advanced EHR systems and clinical decision support tools, which are so readily adaptable to changes in these global outbreaks. I think at a more basic level, though, one of the other kind of strengths of the program, as I've seen it, is just close collaboration with folks in the ED, talking to folks at ED triage and other points of entry for patients about what is practical, and the ability to implement even more simple screening tools at multiple sites of entry across a healthcare facility, posting signs, educating some of the front desk staff who might not be as kind of in tune to some of the infections of concern, but can be readily trained to ask questions about travel history and basic symptoms. That collaboration with the people actually greeting the patients when they come into healthcare facilities is so valuable.
I think that's a great point. It also can be married with standard respiratory etiquette. So respiratory etiquette, as many of you know, is really agnostic to anything related to travel, and is our way of messaging to patients and visitors that if they have symptoms of a respiratory virus or fever or other kind of cardinal symptoms, to first put on a mask, and that provides source control, and then to let someone know about it. And then comes to what Dr. Dugdale was mentioning, is that close collaboration, so that if a patient is presenting themselves, or when asked about their symptoms, provides a positive symptom or travel history, what are the exact next steps to do, and who do you call next? And again, that's that identify, isolate, inform framework. So working with your all those people that Dr. Dugdale mentioned, I think the other piece is around practicing it. And there are really terrific mystery patient toolkits that are available, and which are highly effective and short kind of micro exercises that you can do, where you have someone present to a clinic or an emergency desk triage, reporting symptoms, and if they're questioned and a travel history is revealed, that should prompt initial isolation, that you get a sense of whether or not the teams there have really absorbed that information and are able to implement in that mystery drill setting. So there are many resources online to try to test your workflows. Okay, I'll move on to the next one, which is from a listener who says, our facility doesn't have a high-level isolation unit. do you have any specific training or education recommendations to help us safely isolate and care for these patients? And certainly we have resources, and I'll probably ask Stephanie Lane or some of our other team members to provide links or somehow connect you with some of the resources that we do have available. I think one of the pieces that this addresses is that each facility, whether you have a high level isolation unit or not, those initial steps of identify, isolate, inform are getting you 95% of the way there, because once you do the inform part, you'll have a lot of assistance available to you through public health, through other people who will help guide you through the rest of the workup. And as you saw with all these cases, and what is our general experience, is that once additional history is obtained, generally we're able to determine that a patient doesn't meet the criteria, and you can move on with your with the workflows. So I think that's really critically important. I see that Dr. Lazarus is probably going to talk about how important it is to be able to move on to that the other diagnostic workup. But I think the second piece is that once you've connected with public health, that's where you're going to get guidance on if the patient does meet criteria for testing, what will be done at your facility versus what can be supported in terms of any potential need, depending on the acuity of the illness of the patient or the level of risk, the level of certainty that this might actually rule in as a PUI, what other assistance is available. So I think the focusing on the identify, the isolate, and the inform part will get every facility very far along in this process. Dr. Lazarus.
I mean, I'd just like to echo what Dr. Shenoy has said, particularly about the usual infection control practices that we all should be following. You know, there's an example for Ebola that was actually undetected upon initial admission to a South African hospital. But because of good baseline infection control practices, such as hand hygiene, remember that the dominant mode of transmission for these VHFs is through contact. Though there were many potential exposures, there was really no onward transmission in this hospital. So hand hygiene is very important, and you know, controlling the source of every patient with a potential respiratory infection will also control the source in the rare patient that has MERS or avian influenza.
Great points. I think this kind of lends into the last question, but I'll mention in addition to that one example that Dr. Lazarus mentioned in South Africa, there was a terrific paper published, and if I pull up the PubMed reference, we can put it in the chat, of a patient admitted to a hospital in Minnesota with loss of fever, and it went at least a couple days undetected or didn't get on the radar. And yet in those cases, despite multiple exposures in both community and healthcare settings, again, the standard infection prevention and control practices that we should be doing every day get you very far. Just a point about transmission for Lassa fever and Marburg virus. I'll ask Dr. Lazarus and Dr. Dugdale if they want to join in and talk about the primary modes of transmission for these pathogens. Dr. Dugdale?
Yeah, thanks. So I would just reemphasize that, yeah, airborne transmission, aerosol-based transmission are not primary modes of transmission for any of the viral hemorrhagic fevers. In fact, I'm not aware of any confirmed human-to-human airborne transmission for either Lassa fever or Marburg. But I think interestingly, there have been laboratory-based studies in non-human primates in which aerosol-based transmission of Marburg virus has been confirmed. And there are a number of cases of Lassa fever that have arisen through suspected aerosolization of rodent feces or urine. So there's enough of a concern that airborne precautions are recommended in the care of these patients. But again, as far as I'm aware, human-to-human transmission via aerosols has not been directly observed for either of those viruses.
Terrific. So Maureen Harris is asking about not having the Binax malaria, rapid malaria screening tool. So one of the challenges in a patient who is for which a viral hemorrhagic fever may be on the differential, but for which malaria is going to be much more likely a diagnosis, is that most facilities will not be doing a traditional thick and thin smear just because of handling of the specimens and the laboratory protocols, which makes a rapid diagnostic really useful in these cases. Now, I understand that it's not a very common test. Maybe not a lot of facilities have that available, but I think this is something that your lab could look into, and that we're certainly very open to helping, at least sharing our internal workflows related to this assay. So more to come on that. Okay, great. So we have one question. I think I'm going to hand this off to Dr. Lazarus and then Dr. Dugdale. Let's talk about the differential diagnosis and how often things like malaria come up.
Yeah. I would like to also echo what Dr. Shinoy said about the Binax malaria. It's a really important screening tool. All right, so yeah, Mia is right on with her question there. They often receive another specific diagnoses, and the patients that are ill, it is usually malaria. Remember that these patients that are returning from overseas, particularly Africa and Southeast Asia, with an infection, it is most commonly either the common infection that we would see in the community, like human adapted influenza, COVID, RSV, other human respiratory viruses, or more common infections like malaria, enteric fever, tick-borne rickettsiosis. So while we have to have systems in place to identify these rare patients with very consequential and fatal infections like HCID, we really, and thank you for asking this, we really shouldn't lose sight of the much more common, still quite morbid infections.
And I'll just dovetail on that to put in another plug for the rapid malaria testing, because I think, as I don't know, Dr. Shinoy may have mentioned, but in addition to any sensitivity or specificity concerns with the test or thin and thick smear considerations, they're just the operational logistics of having a pathologist review the slides at 2 in. It seems like half of the calls we get on patients with suspected viral hemorrhagic fevers are after hours, and it can be challenging to have a well-trained laboratory staff present at those late hours to actually review the slides. And for whatever time we're waiting on a confirmatory diagnosis, if that's necessary to really adjudicate the case in terms of this patient potentially being a PUI for a VHF or not, lack of access to testing like the Binax may unfortunately impede further care. And of course, it's important to do everything possible to make sure that doesn't happen, to provide necessary care to the patient using PPE, and to develop laboratory protocols that allow for the other tests that will aid in that patient's care to move forward. But things like a rapid malaria test can be very high value in those situations.
Well, we are coming down to the wire here. I do note, Maureen, the costs and the other aspects that can be prohibitive for rapid malaria diagnosis, but I think that's a great topic for a future webinar where we can really dig into the microbiology lab sorts of considerations and perhaps think of ways that it could be doable in a variety of settings. So I just wanted to thank again the organizers and Dr. Lazarus and Dr. Dugdale and all of you for all the excellent questions that came through. This recording, as we mentioned, will be available on the RDHRS website. And in the chat is the information in order to get your credits. That's just been posted. So you have to text VAZVAC to 857-214-2277. Thank you so much to everyone, and we will see you soon. Bye-bye.